COVID patients, as they transition from hospital through to home, it's going to be nurse-led. It's going to be supported by a multidisciplinary team of allied health professionals who'll be able to bring sort of a holistic approach and support network to those patients as they transition from hospital through to home. So in regards to how we marry the two together, that is the challenge. I think that's the challenge that will be discussed again tomorrow. I think, I am on right.
How comfortable are you with that, Minister? Sorry for cutting across.
No,
how comfortable are you with that?
Well, look, my main responsibility has been that of our health service, and that's why we've brought forward the recommendations that we have in the past, and that's why we'll bring forward further recommendations, both not just on restrictions, but also on innovation as well. So that's why we talk about mass testing vaccines, which will be some way down the line, because we have to give that option of hope as well, but not let it be clouded by the realistic delivery of those. So I've made it clear, I've been in many media reports saying I wasn't content with where we finished up in the executive the last time, because I didn't get what I wanted, but what we got was better than the restrictions falling.
Okay, my second question to Professor Ian Young. Professor Young, when it comes to rapid testing, in order for this to be effective and in order for it perhaps to give us a better Christmas, it would need to be implemented pretty soon. So how likely or how soon will Northern Ireland hear if rapid testing is to be introduced here in order for it to be effective in time for people coming home for Christmas, in order to see friends, and in order for it to be a better Christmas?
As the CMO has indicated, there are some pilots which will be getting underway very shortly to look at the potential for targeted rapid testing in different sectors to reduce transmission of the epidemic. The concept of wider testing, which Minister has mentioned, is an exciting one, but I think it's important to be aware of the limitation of the approach. There are very few places in the world which have attempted to suppress this epidemic in the context of fairly widespread community transmission through the use of mass rapid testing. Where that has been done, I think what people have seen is that to achieve success, you need to successfully test a very high proportion of the population, ideally of the order of 90% or more, which would present enormous logistical challenges. Even doing that, it would be necessary to test the entire population repeatedly in order to achieve and maintain suppression of the virus. The tests which are most commonly used and which are likely to be used will fail to identify around 30% of cases due to the timing of the testing and the sensitivity of the test in relation to the infectious cycle of the virus. So I think there is something exciting there, but something which also presents very considerable logistical and other challenges, and which would take a significant time, I think, to set up and establish on a widespread basis. And Michael, I'm sure, will comment more in terms of the pilots.
Yeah, happy, Minister. Thank you for the question, Mary-Louise, because it's really important. We're entering a very important time of year for all of us as we want to come together as a society and as families. Certainly there's very advanced work in relation to facilitating the safe return of students who are studying in other parts of the United Kingdom back into Northern Ireland, and indeed from Northern Ireland back into other parts of Northern Ireland to spend time at home for Christmas, and that's important. And it will be using these new diagnostic tests, these lateral flow tests. I'm hugely indebted to colleagues in the testing consortium, particularly colleagues in Queen's University who have extensive experience in these new technologies and who have been one of the pioneering universities across the United Kingdom, and working very closely with our colleagues in the University of Ulster and indeed the other colleges of higher and further education. In terms of the pilots, I think it's very important that we emphasise that these are new technologies, new tests. We have to validate them. We need to make certain that whenever we detect a positive, it's a true positive. And when we're advising someone that the test is negative, it's a truly negative test. And that's where they will work best. So we will be trying those and are indeed piloting those in a range and different settings, in healthcare settings. But also we'll be looking to work right across government to ensure that we're also using those technologies in a range of other sectors where we know the risk of transmission of the virus is higher. But as I say, we will deploy those as soon as we possibly can, but we will also need to ensure that we deploy them effectively where they work best and to best effect.
Good evening all, Rebecca Black from PA Media. Minister, there's been talk in England today, the government's medical advisor Susan Hopkins, on a plan to make Christmas as close to normal as possible. Has there been any discussion within the health department, within the executive in Northern Ireland, with any sort of, similar sort of thought in mind? And I suppose to give people a bit of hope on the horizon in what are quite bleak times at the minute.
No, and Rebecca, it is about that hope, about how we get the transfer of COVID down now, so that we can look for that hopeful and that different type of Christmas, that more special type of Christmas. It's actually a piece of work that's been done across all four nations. First and Deputy First Minister and First Minister for Scotland, First Minister for Wales and the Prime Minister are involved in conversations and meetings to make sure that how we spend our Christmas period is the same across the United Kingdom, so there is no difference. And that's why we've seen that sort of joint working approach in regards to making sure we get our students home for Christmas, no matter where they live across the United Kingdom.
Okay, thanks, Minister. Can I also ask? It's been documented that you have been the target of threats by people who are maybe angry, frustrated about the pandemic. Are you having to have any additional security or protection, and the Chief Medical Officer and Chief Scientific Advisor too, in light of some of the attitudes by some elements in society at the minute?
Rebecca, thanks for that. I know there have been a number of threats, and the police and the court services are aware of those and dealing with those. I didn't take up any additional security measures because I thought that was the wrong signal to send out to the people in Northern Ireland. If we were in the middle of a pandemic, when that would have been necessary for a health minister to undertake that, I think would have been a very wrong signal to send out. I'm thankful that those are very few in number, and in fact over the last number of weeks I've been hugely, I suppose, humbled by the number of messages that we are receiving in the department, across our health service, thanking our healthcare workers for the work that they are currently doing, acknowledging the work they're doing, and especially acknowledging the work that they are going to have to do over the next few weeks. So I think it's incumbent on us to ensure that we support them as much as possible by making sure we reduce the amount of community transmission as much as possible.
Good afternoon, Tara McLaughlin, downtown Kill FM. I wanted to pick up on the possibility of mass testing. I think the Chief Scientific Officer said there may fail to identify 30% of cases, and the CMO alluded to false positives and false negatives there. How reliable then is our testing, and how accurate is it?
Michael, do you want to pick up specifically on the,
Sure.
I suppose, the mass testing or our current testing?
Thank you, Minister. Rebecca, thank you for the question, and I think it's an important point to clarify, because we are talking here about new technologies, new tests, as opposed to the PCR test, the normal test that we use in what we refer to as Pillar 1 and Pillar 2 of our testing. The PCR test is the gold standard for diagnosing COVID. What we're talking about here are these new tests, which are basically designed to reduce risk. They're not as sensitive as the PCR test. In other words, they may not necessarily pick up all of the cases, but they are very specific tests, and indeed they will have a place. So for instance, there is the option of using those tests on a regular basis, say twice a week. in healthcare workers to reduce the risk then of healthcare workers transmitting infection or bringing infection into the workplace, and the same would apply in a range of other settings. But as I say, that's why it's hugely important that we don't rush to the next new thing. As Minister said, there is no silver bullet, there is no one thing we need to do. We know the measures that work, we need to stick with the measures that work, and yes, we will push ahead with no poverty of ambition about the new technologies and their role in place, but we need to be absolutely certain that we're sure of their place and where they work best, and that's what we're doing currently through our expert advisory group on testing, working in partnership with the scientific consortium, with industry, with our universities, and as I say, we will deploy those tests as and when appropriate.
Ian, do you want to pick up anything on those tests in regards to sensitivity and specificity?
As CMO has indicated, all tests have limitations in terms of sensitivity and specificity, and that's something which the service factors into clinical understanding and policy when it comes to saying how tests should be used. The main issue with sensitivity is that there is a period when people are carrying the virus, but the virus is not being released in significant amounts, and it's not present in saliva or in swabs. So the main problem with sensitivity is conducting the test too early during the period of infectiousness, and none of the tests will pick up the virus under those circumstances. All of the tests that we use have the potential to give a false positive result. People ask about that quite a lot and speculate that there are many false positives. In fact, the evidence is absolutely conclusive that the number of false positives is very small whenever the tests are used appropriately. So whenever you test individuals with relevant symptoms, when they get a positive test, probably only 1 in 1,000 or less of those tests will be a false positive. If you apply testing in a population who are completely healthy and have no symptoms, then there will be rather more false positives than that. But the tests that would be used in terms of mass screening will have been very carefully validated to keep the number of false positives to the lowest possible level. And whenever the CMO talks about validation of the tests, that's one of the key things which need to be assessed before they're widely used.
Thank you for that. And for the Health Minister, the CMO did mention there about, not rushing or jumping to the next thing. We have heard some concerns among clinicians about any potential vaccine that perhaps it may be being rushed through. Would those be any concerns that you would share? What are your thoughts on that?
Well, look, we won't be using any vaccine that's rushed through. I can make that very clear. We will only utilising vaccines that have been through the full process, the full rigour, and have been fully tested and certified by the appropriate authorities. I think there is some confusion, and I think it's about the speed or the timeliness of some of these vaccines receiving those accreditations. But I think when we look to other vaccines that have been utilised in the past, some of the time that has been taken has been due to funding bids to get them supported, looking for production facilities, looking for government buy-in, or actually clinical support. Whereas from the very outset in the production of a COVID vaccine, all those things have been in place prior to the vaccine actually receiving that final certification. So there's a lot of preemptive work has been done. One of the benefits that we have here in Northern Ireland is being part of the UK pre-buying of vaccines, and they've pre-bought up to 6 different vaccines actually before verification or validation, so that when they come online, when they are validated, when they are deemed safe, that we will actually be able to pick them up pretty quickly. But let's be clear again, that idea of vaccination on its own being a solution isn't coming into next year when it's in the quantities that we need people to be receiving it. Are we hopeful there will be a vaccine being able to use towards the end of this year? Yes, it will be. We think it will be, but in small doses. So we will start utilising it as soon as we can get a safe vaccine that is able for us to use. Michael? Or?
Yeah, thank you for that question. I think it's really important to address this. We will only use a vaccine where it's safe and where it works. Under no other circumstances. There will be no corners cut, shortcuts. A vaccine will be approved only when the regulator has independently looked at it and is convinced that, one, it works, and two, it's safe to use.